Welcome to our second and last video on nephritic syndromes. Let's begin. We'll discuss IgA nephropathy, also known as Buerger disease, and Alport syndrome. Here's an overview of the topics we'll discuss in relationship to IgA nephropathy. IgA nephropathy is an episodic nephritic syndrome. It can occur spontaneously or in association with respiratory or GI tract infections. Let's talk about pathophysiology. Respiratory or GI tract infection results in increased IgA production because IgA normally covers mucosal linings. IgA then combines with microbial antigens. Consequently, there is IgA-based immune complex deposition in the renal mesangium, causing inflammation. The patients with IgA nephropathy will often have a history of upper respiratory tract infection or gastrointestinal infection several days before their spontaneous onset of symptoms of nephritis. The symptoms of nephritis may include the classic signs and symptoms that we discussed earlier in the lecture, and episodic hematuria, flank pain, and low-grade fever. Additionally, IgA nephropathy can be part of the systemic vasculitis. Henoch-Schönlein purpura is characterized by palpable purpura on the legs and buttocks, joint pain, and abdominal pain. This is an image of the patient with Henoch-Schönlein purpura. Please note these palpable purpura on the legs and buttocks. A 20-year-old man comes to the physician reporting dark urine and hypertension. He's been having sore throat for 3 days. He had dark urine and hypertension last year when he had gastroenteritis. He was asymptomatic between these episodes. What is the most likely pathophysiology of this patient's condition? This patient presents with dark urine and hypertension. He's been having sore throat for the last 3 days. The dark urine suggests hematuria. Hematuria and hypertension during respiratory or GI infection are consistent with the diagnosis of IgA nephropathy. Respiratory and GI infections cause increased IgA production. IgA then binds to microbial antigens, forming immune complexes. These immune complexes deposit in the kidneys, causing IgA nephropathy. Let's move on to diagnosis. As with all nephritic syndromes, the urinalysis will be positive for blood, protein, and red blood cell casts. The 24-hour urine protein excretion rate is usually less than 3.5 grams. It's very high yield to know that the complement levels are normal in IgA nephropathy because IgA cannot activate the complement. This is in contrast to post-streptococcal glomerulonephritis, which is characterized by low complement levels. Patients may also have increased creatinine secondary to the kidney injury that occurs with IgA nephropathy. Renal biopsy shows characteristic findings in IgA nephropathy. Light microscopy will reveal mesangial proliferation. Immunofluorescence will have granular pattern due to immune complex deposition. Finally, electron microscopy will show mesangial immune complex deposition. This is the light microscopy image of the patient with IgA nephropathy. You can see the mesangial proliferation characteristic of this condition. This is the electron microscopy image of the patient with diffuse proliferative glomerulonephritis. You can see the mesangial immune complex deposition. Let's talk about management. If the patient with IgA nephropathy has normal creatinine and proteinuria of less than 500 milligrams per day, then observation is sufficient. Often the condition will self-resolve. If the condition is moderate or severe, we should initiate systemic corticosteroids. ACE inhibitors should be added for proteinuria and hypertension. Finally, it's important to recognize that while this can self-resolve in some patients, it can progress to end-stage renal disease in some patients. Some risk factors for progression to end-stage renal disease include hypertension, increased creatinine, and persistent proteinuria. A 12-year-old girl presents with dark urine and puffy eyes. She's had pneumonia for the past 2 days. She had similar complaints 3 years ago when she had sore throat. Her serum creatinine is 0.8, and protein excretion rate is 300. Streptococcal antibody titers are negative. What is the best next step in the management of this patient? This patient presents with dark urine and puffy eyes. She's had pneumonia for the last 2 days. She had similar complaints 3 years ago when she had sore throat. This description is consistent with the diagnosis of IgA nephropathy, especially since she has negative streptococcal antibody titers. Since her creatinine is normal and the proteinuria is mild, observation is sufficient for this patient. Finally, let's move on to Alport syndrome. Here's our overview slide of the topics we'll discuss in relationship to Alport syndrome. Alport syndrome is an X-linked dominant genetic disorder associated with kidney disease, hearing loss, and eye abnormalities. Alport syndrome is caused by mutation in type 4 collagen. This mutation results in irregular thinning and thickening of the glomerular basement membrane, which induces nephritic syndrome. The clinical features of Alport syndrome can be remembered by the mnemonic can't pee, can't see, can't hear a bee. First, these patients have the classic nephritic syndrome with hypertension and hematuria. Additionally, they have eye abnormalities like retinopathy or anterior lenticonus. This is because the basement membrane of the retinal vessels and the stroma of the lens contain type 4 collagen. Anterior lenticonus is anterior conical protrusion of the lens into the anterior chamber. Finally, since the basement membrane of the cochlea contains type 4 collagen, Alport syndrome can also induce sensorineural hearing loss. This is what the anterior lenticonus looks like. Please note the anterior protrusion of the lens into the anterior chamber through the pupil. In a patient without anterior lenticonus, this protrusion will be absent and there will be normal curvature of the lens. Let's talk about diagnosis. 24-hour urine protein excretion rate is typically less than 3.5 grams. Additionally, fundoscopy can reveal the abnormalities of the retina and the lens. Audiometry can detect the sensorineural hearing loss. Patients should also go through genetic testing for a diagnosis. Finally, the renal biopsy and the electron microscopy will show the basket weave appearance of the glomerular basement membrane due to irregular thinning and splitting. This is the electron microscopy image of the patient with Alport syndrome. You can appreciate this basket weave appearance of the glomerular basement membrane due to irregular thinning and splitting. Management is focused on treating the individual signs and symptoms. First, systemic corticosteroids, ACE inhibitors, and angiotensin receptor blockers are used to delay progression of nephritic syndrome. ACE inhibitors and ARBs can also be used to manage chronic kidney disease. Renal transplantation can be performed in refractory cases. Sensorineural hearing loss can be treated with hearing aids. Finally, if the patient has anterior lenticonus, he or she can undergo surgery of the lens. An 8-year-old boy presents with diminished vision and hearing. Slit lamp examination shows anterior protrusions of the lenses bilaterally. He also has bilateral sensorineural hearing loss. He has dark urine and hypertension. Renal biopsy is performed. What will most likely be found on electron microscopy of this patient's biopsy specimen? This patient has diminished vision and hearing. Slit lamp exam shows anterior protrusions of the lenses bilaterally. He also has bilateral sensorineural hearing loss. Dark urine and hypertension suggest nephritic syndrome. Vision abnormalities, sensorineural hearing loss, and the nephritic syndrome in a young patient indicate the diagnosis of Alport syndrome. Electron microscopy in Alport syndrome typically shows the basket weave appearance of the glomerular basement membrane due to irregular thinning and splitting. Let's move on to a table to help us wrap up the lecture. Here is a summary table of the nephritic syndromes that we discussed in this and previous lecture. Pause the video and take a moment to consider this table. A 7-year-old boy is brought to the physician due to bilateral leg swelling and dark urine for the past 2 days. 10 days ago, he had a sore throat that was treated symptomatically. His past medical history is significant for bilateral congenital cataracts treated with surgery. Family history shows sensorineural hearing loss in his paternal grandfather. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 155/95, a heart rate of 91, and respiratory rate of 15. Physical exam reveals periorbital and peripheral pitting edema. Urinalysis shows 100 red blood cells per high power field with red blood cell casts. C3 complement level is normal. Anti-streptolysin O and anti-DNase B titers are negative. Which of the following is the most likely diagnosis in this patient? A. Rapidly progressive glomerulonephritis. B. Alport syndrome. C. IgA nephropathy. Or D. Post-streptococcal glomerulonephritis. This boy presents with bilateral leg swelling and dark urine for the past 2 days. Right from the chief complaint, one can suspect nephritic syndrome with hematuria causing acute kidney injury and water retention. 10 days ago, he had a sore throat that was treated symptomatically. Nephritic syndrome after a recent upper respiratory infection points to either IgA nephropathy or post-streptococcal glomerulonephritis. His vital signs are significant for hypertension with blood pressure of 155/95. Physical exam reveals periorbital and peripheral pitting edema. Urinalysis shows 100 red blood cells per high power field with red blood cell casts. These latter findings confirm nephritic syndrome. C3 complement level is normal. Anti-streptolysin O and anti-DNase B titers are negative. IgA-based immune complexes do not activate complement system. Therefore, normal C3 complement level as well as negative streptococcal titers favor IgA nephropathy over post-streptococcal glomerulonephritis, so the correct answer is option C. Again, here is a summary table of the nephritic syndromes that we discussed in the lecture. Pause the video and focus on the distinguishing features of these conditions. Let's discuss why other options are incorrect. Option A is incorrect because this patient does not have rapidly progressive symptoms or anuria. Additionally, IgA nephropathy usually has good prognosis in children and results in full recovery. Option B is incorrect because although this patient has a history of congenital cataracts, Eye problems in Alport syndrome include retinopathy and anterior lenticonus. Additionally, bilateral sensorineural hearing loss in his paternal grandfather is most likely an age-related decline in hearing rather than a sign of a genetic syndrome. Finally, option D is incorrect because, as we already mentioned, post-streptococcal glomerulonephritis is characterized by low C3 complement level and high anti-streptolysin O and anti-DNase B titers. And that concludes our lecture on nephritic syndromes.